Hello, everyone. Welcome back to another session here with PHS. We're going to go ahead and get started. So my name is Hiba, and I'm one of the PH leads here in the Life Sessions Department at Pre-Health Shadowing. And I'm very honored here to have all of you guys. A warm welcome to our return students and all our new members here that are joining us for the first time. Welcome. A little bit of presentations about who we are and what we do. We are Pre-Health Shadowing, an international student-led, women-led, minority-led, and nonprofit organizations for medical advancement. We do like to accommodate for all of our students' abilities and needs. So during our all of life sessions, we do have closed captions for you guys to accommodate all of you guys' needs, languages, or any purposes that you will need it. For any future ideas or accommodations that you guys like us to take into concern, you can always email us at our board email, which is at info@prehealthshadowing.com. And we always look up to hear any of you guys' feedback, ideas, or anything that can make our live sessions more accommodating and meet all of you guys' needs and abilities and concerns. We do like to have students stay more into the loop with us here at PHS. So to stay into the loop, you can always join us through our social media platforms like Instagram, TikTok, and LinkedIn as well. And we share the same handles, which is at Pre-Health Shadowing. You can always sign up for our emailing list, which is on the website. It's a very easy, quick form that you can fill out with your email name and what you look up to for to join us. And you'll always stay in the loop. You get our weekly emailing list and newsletter with our upcoming sessions, events, and everything that's new within our org. We do have students from all over the world, which is something that I truly love. It's always that we have a majority or just people from everywhere. So please go ahead in the chat, let us know from what state or country that you are joining us so we know where our participants are here from today. Dallas, California, nice. New York, North Carolina, welcome everybody. Illinois, Michigan, New Mexico, Pennsylvania, California, Illinois, Indiana. Perfect. Thank you guys for answering in the chat. We're gonna go ahead and get started again. Okay, so our next thing here, we do like to recruit a lot of students and to join our board. You can always join in different ways. We do have a volunteer program. You can just join as a volunteer if you don't think you have the biggest or the largest commitment to join for our program. We do offer a lot of leadership positions throughout all of the departments. For example, we have our IT department, we have the grant department, we have also a research department that have been starting and have been doing a lot of such awesome job with like matching mentors and students to do research. We do have high school department. We have our live sessions. You guys can always join in different departments as we have. Again, you can always join as a volunteer, or you can also join as a leader on the team, which kind of takes a little bit more hours or more responsibilities into it. But anything that you would choose to be with us, we're very honored and lucky to have all of you guys. We do have our high school program, which is offered for all of high school students all over, which focuses on getting the resources for students that want to step into pre-health, like healthcare education or any college resources that they need for them to transfer from high school to college, which is such a great program. And we have been spreading a lot in a lot of high schools schools in the US here and have been doing such a great job. So if you're a high school student, you can always go ahead and join the program. We have a very short form that you can fill out on the website, and they will get back to you as soon as they can. Again, this is a nonprofit organization, so it's all free for you guys and for anybody that join us here now or later in the future. But to keep it that way, free for you guys, free of charge, we do rely on donations. So if you can go ahead, scan the QR code, and then donate as much as you can, whatever you can. Any dollar can make a difference. And remember, you're helping all students like yourself to keep or have this amazing opportunity for all free. And being in a pre-health for sure is something not as easy, and to have all of these resources is something awesome. So you can go ahead, save it, scan it, or also share it around the family, the members that you know that can also help us to get donations. We would truly appreciate it. As we go throughout the session, we will have our amazing professional here share their slides and talk through all of the amazing presentations that they have for us. Feel free to type your questions in the chat, and we will have a Q&A section at the end. We will be able to unmute or type your questions in the chat, and of course, we'll read them off and have all of your questions answered. Again, this is just an amazing presentation as it will be. So feel free to take any notes that you want to take, or anything, a resource that the professional here will share for you. All of that is for you guys to have the help and the resources as much as you can. So feel free to use it and advance from it as much as you want. Since we're all remote and it's something very important to keep the live sessions more engaging and welcoming and all of that, it will be very awesome to have as many of you have their cameras on. So it will be awesome. So please go ahead, do so if you're able to do so. It will keep us all connecting, especially that we're on an online platform. And that's all for my presentation right now. I'm gonna go ahead and passing on to our professional here. Please go ahead, take the floor and share your screen.
Great. Thank you all so much for joining us here tonight. I am Emily Cleveland Manchanda. I use the she series pronouns. I racialize as white, and you'll hear a little bit more about my background as we go through the presentation. So in terms of an introduction, I will sort of leave it at that. I'm pausing before I share my screen because I know as soon as I do, I will lose all of your beautiful faces on my screen. And so I just want to have a moment to see each of you. But welcome and thank you so much for joining us. I tonight would like to talk to you a little bit about how I have been able to create opportunities, both personal and professional, to live my values and to advance equity in healthcare and beyond, not just through my professional or compensated work, but also a little bit in how I and my family have chosen to live our lives. And so I'm going to walk you through a story of sort of how I got to be where I am today. But before I jump in, I want to start with a land and labor acknowledgement. And this is something that all of us at the American Medical Association Center for Health Equity begin each of our presentations with. We acknowledge that we're living off the stolen ancestral lands of Indigenous peoples, which they have cared for since time immemorial. We also acknowledge the extraction of brilliance, energy, and life for labor forced upon people of African descent for more than 400 years in this country, and elsewhere, of course, as well. We celebrate the resilience and the strength that all Indigenous peoples and descendants of Africa have shown and continue to show here and worldwide. And we carry our ancestors in us. I'm personally compelled by that piece of it, being called to do better and be better as we lead in this work. It's also important to notice that, as we center justice in our work, we are moving from a state of recognition to the ability and creating spaces and opportunities to be active in our equity endeavors and to move to a frame of repair, including reparations and, where possible, reconciliation. This requires intentionality, right, in both naming harms and their consequences and committing to action to build them. And so I offer this acknowledgement really as a starting point of recognition and an openness to creating opportunities and taking action myself and in my choices in my life to create spaces of repair. And so you'll see a little bit more of that. Tonight, I'm speaking to you from the lands that were ancestral lands to the Massachusetts and Pawtucket people, where many of them still reside in what's now called Andover, Massachusetts, about 20 miles north of what's now called Boston. And so tonight, I will sort of tell you my story. It's a winding road, and I hope that you'll take away from this a sense that you don't have to have it all figured out right now, and certainly not when you're a med student, and certainly not even when you're a resident if you choose to go into to sort of the path to become a doctor. You have lots of opportunities to shape and reshape your path. And so I grew up with a very privileged childhood. I had an incredibly loving family with well-educated parents, and you'll hear a little bit about my dad in a few minutes in the presentation. But bring this in to note that I have a huge family with many cousins, but also three brothers. And so you see me here in the center, and my brother Dave, who's 2 years younger than me. He would be so mad if he knew I was showing this picture with his long hair. And then twin brothers, Teddy and Nate, who are these little guys sort of on either side of me. And then these are a few of my cousins. The twins are 10 years younger than I am. And so I sort of started out as a caregiver early in my life. And I also included this picture of my brothers with a couple more of my cousins because it shows my grandmother, Seta. And she was a huge influence on why I chose to become a doctor. I basically knew from forever that I wanted to be a doctor because she was one. She's the family matriarch. She had 6 daughters. My mom was the youngest, and she was a physician in Massachusetts in the 1950s and 60s, 40s, 50s, and 60s. When it was incredibly rare for women to pursue a career in medicine. And some of the experiences that she had as a woman in medicine, as a pathologist, really shaped my sense of the world. Her ability to give back also, and the way that she centered that in her home life as well as her professional life, was really deeply influential for me. I went through knowing that I wanted to be a doctor, and had a great advisor who told me at some point in high school, or perhaps my freshman year of college, I can't remember exactly when, that I had med school to learn medicine and that I should study whatever I wanted, whatever would make me a more interesting and well-rounded human in undergrad. And so in undergrad, I ended up studying art history and French, and I double majored in art history and French. And I joined the crew team as a walk-on. And I'm not a rower. You can't tell on Zoom, but I'm 5 feet tall on a good day. I'm relatively small, and good rowers are big. And so this is me, the tiny person here, and over here at the back of the boat, I was a coxswain, which is a role that includes something between coaching and being an athlete. You're sort of in this middleman role, and allowed me to build a lot of skills in team cohesion and team leadership in ways that I didn't fully recognize at the time. But that was a really formative experience for me. Because I was double majoring in undergrad, I really wanted to take a break. Not a break to go sit on a beach for a year, but I wanted to go be useful in the world for a year. I was also in undergrad reading some really compelling physician justice writers, including Paul Farmer's work. I don't know if folks are familiar with Paul Farmer and his work at Partners in Health. He died last year, the year before, unfortunately, much too early. But he was deeply influential on my sense of justice in the world. And in an effort to be useful, I volunteered to work for the Clinton Health Access Initiative, which was at the time the Clinton HIV/AIDS Initiative, through some work that they were doing in a very early stage office that they had just opened a few months before in Monrovia, Liberia. And I went over there as a volunteer for 3 months. And the Clinton Foundation it's not like a medical tourism volunteer role where you pay to be there. As to experience a country. I was working 60 to 80-hour weeks, functioning as a junior consultant on a team, doing what I was told, reformatting documents, making PowerPoint presentations, that kind of thing, in a space where a 22-year-old with a college degree only, as their only lived experience, could actually be useful. Liberia was just coming out of a 30-year civil war, had elected a new government, including run by Ellen Johnson Sirleaf, an amazing Liberian economist, as their president in 2005. And I came in mid-2007. And helped the health ministry, where I was sort of seconded to the Ministry of Health, to the equivalent of their Surgeon General's office, and helped Dr. Dawn and her team understand where clinics were in the country, who was operating them, and what services were being provided. And some of that was done through direct site visits. St. Francis Hospital is one of the major hospitals in Monrovia. I give that as an example of this is the equivalent of a Beth Israel or a MGH, not quite MGH. They have JFK Hospital, which is sort of the equivalent of MGH, but it's a major urban hospital. And this is what things looked like from the outside at the time. And the roads between cities were incredibly treacherous. And so the team that I worked with was incredibly dedicated. And this experience of working at the central government level really shaped my understanding of what is possible, and the role that powerful organizations like government can take in shaping and creating opportunities for health for their populations. It was a really formative experience for me. It also made me realize that central level, national work, made me feel far from the people that I had an impact on, the people that I was working for, and that I didn't want to just do public health work or government level work. I wanted to be more proximate to the people who were experiencing both harm and benefiting from some of the work I was doing. My time in Liberia was also influential. I ended up being there for almost 2 years. I got talked into deferring med school for a year to stay to run another round of our program. And it was also an important time in my life because I met this guy who's also next to me in this photo over here. His name is Gaurav. He was then my roommate and one of the other folks who worked for the Clinton Foundation. And 17 years and 3 kids later, he's my husband. And so I'm not recommending that any of you date your roommate or your colleague, but sometimes you meet the right person in the strangest of places. We actually know a number of folks who met in Liberia and jokingly say Liberia is for lovers. But he followed me back to the US and to med school. I went to medical school at Penn, which was close to my family's home in the Philadelphia suburbs. And in our 4th year, we got married. I'm going to gloss over his influence in my life because I don't want to talk to you all for like 6 hours, but he is also an amazing human who really centers justice in his work. He is Indian, was born in Delhi, grew up mostly in the US, and that has been also an influential part of our life here in the US. And so match day in medical school brought me to a specialty that I think might be surprising given sort of my roots in Liberia, but I matched into plastic surgery. And I thought that I was going to do global cleft palates and burn reconstruction work, and saw that there were reasonably ethical and well-structured ways to do that in international health settings without just parachuting in and parachuting out, like dropping in and doing something and then leaving a community without that resource. There were longitudinal programs for surgeons to work through. And so I matched into plastics and I went to NYU, which is a mixed program between NYU Langone, the private hospital in New York City, and Bellevue Hospital, which is one of the public city hospitals, and had almost 2 years of plastic surgery training under my belt, the pager belt being one of the proverbial belts. That's like the overnight intern on call when you're covering multiple services and taking consults. That was a very formative and very stressful part of my life. I the whole time going through the plastics training sort of knew what I was getting into, knew that it was a come early, stay late, old school boys club training program. And it looked to me like most of the folks on here may identify as women. I don't want to presume anything, that I'm talking to mostly women, but that seemed like it from the photos I saw on the screen. But I went in sort of with my eyes open. Like I had spent a month at this place as a visiting, like rotating medical student, and sort of knew what I was getting into. And when I got pregnant, there was not a ton of support in my program. And when my son was born extremely prematurely, there was very, very little support for me in the program. And so unexpectedly, Sebastian, my now 9-year-old, was born at 25 weeks and he weighed 1 pound, 12 ounces. It's a little over 800 grams for folks who operate in that system. And he really disrupted my professional life in ways that have turned out to be really wonderful. I wouldn't wish this experience on anyone, but we spent 4.5 months in the NICU. He came home on oxygen for his first year of life and had immense complications. But the process of stepping away from my surgical training, and Gaurav being the saint that he is, saying to me, you don't have to go back to that if you don't want to, when I was having a lot of anxiety about going back to work as a surgeon, gave me the space to pause and reflect and think about what I actually wanted. And got some really good advice from folks who encouraged, my mom actually, who encouraged me to make a list of the types of work the things that I needed in my professional life and the things that I wouldn't tolerate in my professional life. And then a middle list of like the things that are nice to have. And it wasn't like be an OBGYN or like be a physician assistant or be a nurse. It was like work with smart people, have a job that lets me see sunshine on most days when it's sunny, have a job that gives me the flexibility to move cities if my kids' medical needs mean that I have to. And that helped me to make some more difficult decisions about what type of a career I wanted to have. And so I decided that I was going to shift professionally into emergency medicine. And there were a number of reasons that I did that. And I'm happy to talk about emergency medicine and the ways that it creates an opportunity to have sort of multiple professional identities. If that's something that folks want to talk about. That's not where I'm going to focus most of my time, but the shift to emergency medicine, like the grass really is greener for me. I think if I'd been in a different surgical training program, that probably would have been a different path, but I'm very, very pleased with where I ended up. But in the interim, while sort of reapplying in emergency medicine, I made it about 10 days as a stay-at-home mom, before I realized I was going to lose my mind, as a stay-at-home mom. That was not my source of joy. I spent a lot of time worrying about every little twitch that Sebastian had, and maybe that was gonna be a seizure, maybe this was gonna happen, and I had a really hard time sort of managing that. And so, decided to get my MPH, and sort of last minute talked my way into an MPH program, at Mailman. And when I was at Columbia that year, also had an opportunity to reflect on where things were in our country. It was 2015 to 2016. Um, Mike Brown Jr. had been murdered the summer before. Eric Gardner had been murdered more recently in New York City. And being in a school of public health on the Upper West Side of Manhattan was a really different experience than being at Penn when I was there. I was also in a different frame of mind. And so I got a deep dive into structural violence and injustice and began to have a stronger racial equity lens and shifted from thinking about doing predominantly global health work to focusing more on the spaces where I had influence and felt more personal responsibility to redress harms caused by my ancestors here in the United States. And so when I shifted to emergency medicine, I moved up to Boston. We all moved up to Boston, which was a family choice based on resources for Sebastian, as well as being proximate to our other family, and the opportunity for me to jump into sort of a second year residency spot at the Mass General and Brigham Emergency Medicine Training Program. And during my clinical training, the balance of time is a little bit different than when you're a surgeon. And I spent a lot of time, particularly after the 2016 election, doing a bunch of unlearning about how I thought America worked. And I did a lot of that with support from these two incredible women, Denny Butler McKay and Abigail Ortiz, who are racial justice trainers and social workers at the Southern Jamaica Plain Health Center in Boston. And we lived in JP, and the trainings that they led are incredibly immersive opportunities for people from all different backgrounds. They work with high schoolers, they work with attending like vice chairs of medicine at academic medical institutions at Harvard, and everybody in between, to help folks develop an understanding of how racism operates in the country. And they led some programming specifically for physicians that was really formative in my own learning. I also went to an adult education course at the Cambridge Center for Adult Education called White People Challenging Racism, because I needed some more intensive work around my whiteness and what it means to be white in America. And found that work really, really helpful. And they actually, I think, offer virtual classes. I'm not sure if there's a cost to it, but their work was also really supportive of me as I sort of worked through this. At the same time, I was thinking about how I applied anti-racism work to my professional life. I was also thinking about how we chose to live our lives. And a lot of this coincided with other national movements around like Standing Rock and water rights. And we shifted our money out of Bank of America and into One United Bank, which is the largest Black-owned bank in the country. We shifted how we were paying our nanny and how we were paying the folks who help clean our house to be more equitable and fair in our compensation for people. And so there were changes in both my professional lens and the personal lens that contributed to starting to kind of align the way I was living my life to my values. And I want to digress just a little bit to share sort of how I think about power and privilege. And I use my family history as a little bit of an example here, um, because I think it's helpful for folks to sort of, I don't know, this is how I see the world. And so it's important to like recognize that there are lots of different types of privilege. Racial privilege is certainly one of them, but there are many different ways in which some people enjoy advantages or immunities compared to others in society. Privilege is a zero-sum game. Like if there are winners, there are losers. And so this, I think folks have probably seen something along these lines. It's like Wheel of Power of Privilege has been like shown in different spaces. But for me, I have all the privilege except a penis. Like have all of these things that set me like closer to central power. And a lot of that comes from my family. And so, my dad, Bob, is the guy on the right here in this red bike jersey. And he works really, really hard, and he always has. Like, having privilege doesn't actually take away from how hard somebody works. They're actually really independent entities. He I'm gonna like not share as much as I always do about him, but if folks are interested, I'm happy to like share more about this whole story. But like looking back a generation further in the interest of time, the guy on the left here is my dad's dad. Um, he went to med school on the GI Bill after serving in the Marines. This is him in either Guadalcanal, Okinawa, Peleliu, or Pavuvu. We're not sure where the photo was taken in 1943 or 44. But if you watch the HBO miniseries The Pacific, that was his unit. And so we're really lucky that he came back and was able to go to med school. He became a pathologist and he married my grandmother, who is an Irish immigrant, first generation. And with $500 and a GI Bill backed loan, they bought their home in Florham Park, New Jersey, in 1954. And this isn't their exact home, but it looked a lot like this. And they went on to live a comfortable middle class and then upper middle class life. But it's important to know that Florham Park, like every other suburb in America that was created in the 1940s, 50s, and 60s, was redlined. It was lily white, and that was not by chance. It was maintained as white only through the creation and enforcement of unfair laws, policies, and practices at the level of the US government, at state levels, at neighborhood association levels. And, it's not that this was like done by accident. It's not just like only white people wanted to live in these lovely neighborhoods. Less than 0.15% of mortgages issued by the under GI bills were issued to people of color. And so all the privileges that my grandfather had in being able to purchase that home and live in that neighborhood trickled down to my dad, who then got to go to good schools and pursue a career as a lawyer. And he's passed many of those same privileges on to the rest of our family. And I should say, like, I can tell the story from my mom's lens too. There's privilege on both sides of my family. It's different. She grew up Armenian with a very different story about the heritage of being Armenian and a persecuted class. My grandmother was born in Turkey as they fled the Armenian genocide. And so it's a different version of a story of privilege, but that has passed down to the rest of my family. And this is Sebastian when he was probably like 3 or 4 cooking with my dad. And so I'm sorry, there's like an auto advance on my slides that I haven't figured out how to turn off, so they keep going forward without me clicking. But I want to like bring this into sort of how I also think about the work that I do in the healthcare space, because it's not just like, oh, I have lots of privilege, like I should recognize that. That really deeply influences how I think about my work and my life. And so I want to show you some maps. This is Boston, and it's a map from the 1930s or 40s that was created by the Homeowners Loan Corporation. The green areas over here, and there were very few within Boston, were places where they would give good loans. The yellow areas were definitely declining spaces, and red were hazardous, where you just couldn't get a government-backed mortgage. It's not a coincidence that this same map can represent a wide range of neighborhood level differences that are not just economic, but health related. And so this is a map of ED visits for kids that are aged 3 to 5 for asthma. And you can see that like the overlay of those hazardous or definitely declining areas is basically identical. And this is from, wait, let me check my notes, like 2012 to 2015. Those darker areas of Roxbury, Dorchester, Roslindale, Chelsea are the same areas that were redlined and where a disproportionate number of Black and brown Bostonians live. And we see this in the COVID pandemic as well, right? The same areas are rates of COVID-19 infections by neighborhood. And so to understand what drives this, like how is housing loans in the 1940s connected to today, I want to offer you an analogy that I really appreciate. This is coming from the Groundwater Institute's work. They point out that in all of our health outcomes, there are differences by racial groups in the US. The red line here shows the likelihood of a bad outcome if you are African American compared to white folks. And they have a flipped version of this. It doesn't use white folks as the reference point, but for the sake of illustrating this, the likelihood of having a bad outcome across all of these different sectors, if you are African American, is higher. And this is true at the national level. That's where this data comes from. It's true at the state level. It's true at the city level across the country. The only exception to this is that sometimes sometimes Native American or American Indian people have worse outcomes than Black folks in America. We have different words for this, though. In health, we call it health disparities. In education, we call it the achievement gap. In criminal legal systems, we might talk about disparate sentencing. In child welfare, we call it disproportionality. And in finance, we'll call it redlining sometimes, or we'll talk about underutilization of minority enterprises, which, by the way, means that like some enterprises are being overutilized. But we have different euphemisms for the same pattern of outcomes. And so the Groundwater Institute builds on an analogy that was offered by Kamara Phyllis Jones, who's a brilliant writer and physician, to explain how this operates and why this comes to be. And so to make sense of this, I want to show you this analogy. So imagine you walk by a lake and you see a dead fish. And imagine you're a doctor. To figure out what happened to the fish, you'd be like, wonder why that fish died. Let's cut it open and do an autopsy. Maybe it got lung cancer and that's why it died. I don't know if fish have lungs that get cancer, but like roll with it. Roll with the analogy for me for a sec. But if you walk by that lake and you see that half the fish in the lake are dead, your frame shifts and your questions start to shift, right? You might start asking, like, what's different about these fish than the fish that survived? You might start doing some genetic testing on these fish. You might wonder, maybe these fish like swam more and ate better, and so that's why they survived, and maybe those fish that died like just made bad choices, right? But you'd probably also wonder if there's something in the environment, like in that water in the lake, that's shifting things. But most of the time we start trying to compare the ones that did well to the ones that didn't do well to figure out what's wrong with the ones that died. If you zoom out further, though, and you realize that half the fish in all the lakes and all the land are dying, you have to start looking for different explanations. You have to start looking to the groundwater. What's connecting these lakes and causing the same outcomes in health, in education, in criminal legal systems, in all these different lakes across the country? And when your frame shifts, so do the questions that you ask, and so does your consideration of what's needed as solutions. And so understanding some of these really foundational ways in which racism operates in the US has been incredibly helpful for me as I work to design system interventions that don't just fix fish and toss them back into poisoned water. Right? Just giving people handouts and propping them up and sending them back to their like moldy apartment is gonna not fix their asthma, right? You need a lawyer to get in with the landlord and mitigate that mold, right? And then we need fair housing policies that don't allow landlords to take advantage of renters to the point where they have mold in their homes and have to hire a lawyer in the first place, right? And so there are many ways in which this analogy works for me in my sort of understanding of what's needed. But it's shifted the way that I think about my role in the work and my need to be both proximate to the fish, to people who are experiencing health problems and health injustice, and to have an influence at national levels to be in the ears of people who have power to make decisions at scale. And so this brings us to sort of 2018, 2019. This is us with Sebastian, who's looking cold, at a rally against the first or second Muslim ban that was proposed by Trump. In 2018, we had another kiddo. This is Kieran, who is now 6. I had a somewhat less complicated pregnancy and a much more supportive residency program at the time. He is a much more feisty child. You can see from his baby photo here, his opinions on being photographed. But this is sort of bringing me into my residency training. And as a senior resident, I had the opportunity to really deepen my understanding of how racism operates at institutional levels. And so I'll share with you this definition of institutional racism, which is a term that was coined in 1967 by Stokely Carmichael and Charles Hamilton in Black Power, The Politics of Liberation. But it refers to the way that people are treated, experience discriminatory treatment in the context of institutions through unfair policies or practices and inequitable opportunities, which originate from the way that sort of established status quo forces work in society. It's a lot more hidden than interpersonal discrimination, right? And so I want to give a couple of examples, but like the most overt of these are like for many, many, many decades, centuries at Grady Hospital in Atlanta, there were 2 towers, one for white folks and one for everybody else. And you'll still hear people, especially elders in Atlanta, refer to Grady as the Gradys because it was 2 towers and they weren't seen as one. This is true in St. Louis, where at the main teaching hospital, people of color were treated in the basement only and white folks were treated upstairs. But it operates still today in different ways. And so I'll share with you one example of a research project that I got to work on as a resident that turned into institutional advocacy and reparations. And so some of the medicine residents at Brigham noticed that when they were taking care of patients who came in with heart failure, on the cardiology service, most heart failure patients were white. And on the general medicine service, in shared rooms with not the nice, beautiful tower and less cardiologist like time spent thinking about them, most of those heart failure patients were people of color and older and more women. And so they started asking, like, is that real? Is that just like we happen to notice this, or does the data bear this out? And they did an incredibly deep and detailed analysis of the data and found that that was a real and persistent racial inequity. And many people asked many questions about how that could be. Was it explained by like people with more severe disease or less severe disease or more mental health or other comorbid conditions? How could we explain this away? And no matter how you sliced and diced the data, you couldn't explain away this racial inequity. It was an example of institutional racism. And the way that it was operating was to give people people of color less access to specialized cardiology service. And the difficult part about it, the part that really entrenched it, was that one of the greatest predictors of being admitted to cardiology was having a cardiologist in the system, right? If your cardiologist was in the system, they'd take you on their service. The problem was that if you ended up on general medicine, you were much less likely to get a cardiology appointment and much less likely to have a cardiologist. And so you ended up in these separate, segregated, and self-reinforcing systems where if you didn't have a cardiologist, you were more likely to get readmitted again, and you were more likely to have been cared for just on the general medicine service, and you were more likely again on general medicine to end up with an increased rate of 30-day readmissions. And so the team that worked on this put together an immense committee with multiple different departments represented, and did some deep racial reckoning work, facilitated by Denny Butler McKay and Abigail Ortiz, who I mentioned before, to build an understanding of what was happening here. And the ways in which this led to institutional change are really important. It's one of the only levels of one of the only examples, excuse me, of institution level reparations that I've seen. This study that we did led to the development and implementation of a program to preferentially admit Black patients with heart failure to the cardiology service at Brigham until this historical imbalance was corrected. And it's not like reparations for the people who were harmed by being excluded from having the opportunity to be cared for in cardiology, but it is a proactive way to address some of these inequities in the community that was harmed. And the folks who really led that work are Bram Wispelwey and Michelle Morse. Bram is still faculty at Brigham. Michelle is now the chief medical officer for New York City. They are brilliant physicians. And they set out this framework. There's a great article that's linked here below, and I can share all the slides that aren't just photos of my kids after the talk if you want to read more about it. But they developed this framework for institutional redress and how we can identify and deal with the institutional harms. The first part begins with acknowledgement, acknowledging the institution, acknowledging what the institution has done. The second piece is creating a pathway for compensation, some sort of a compensatory step to address patients and communities that were harmed by that instance of institutional racism. And the third is closure, exploring community engaged ways of understanding whether that is sufficient or whether more needs to be done to ensure fair restitution for inequities. And this is an ongoing process, right? This is iterative. There's intentionality in the circular path that they've outlined here. And so this brings us to sort of the end of my time in residency and brings us to March 2020. And, as many of you will remember, COVID began in this country in the beginning of March, and I finished residency at the end of 2019, in January of 2020, and intentionally took a gap. I intended to start my academic job as an attending at Boston Medical Center on April 1st, 2020. And so I was out of clinical work, and we took a great family trip to India and spent a lot of time like getting to know my kids again once residency was done. And the way that COVID was unfolding, like at the time we didn't know how it was transmitted. We just knew that like many people were dying, including Chinese doctors who were caring for COVID patients. And so Garv and I made the really difficult decision to have him and our kids and our au pair, like a live-in nanny at the time, leave Boston and move in with my parents in the Philadelphia area. And we thought that was going to be just for a few weeks, and it ended up being for 3 months until the first major wave of COVID rolled through Boston, and there were ICU beds again, and things were a little bit less scary by the time we got to mid-June. But in that 3-month period, I went down a particular rabbit hole around equity in what was called crisis standards of care, or which are triage guidelines for how you ration and how you allocate scarce resources. And in the first wave of these guidelines that came out of Massachusetts, um, there were ways in which inequity was baked into the algorithms, baked into the way that resources were going to be allocated. For example, the Glasgow Coma Scale, or GCS score, is one of the things that was factored into our triage allocation. And that includes measures that without some like mitigating language, can discriminate against people with disabilities who can't follow commands the way that I might be able to say, like, if you wiggle your toe, I can wiggle my toe. Like Sebastian can't wiggle his toe on command necessarily, and certainly not when he's sick. And so that there were built-in discrimination against people with disabilities. And the SOFA score, which is one of the other ways in which people's need for a ventilator, for example, was going to be determined, also inequitably distributed resources away from people of color based on the inequitable distribution of chronic kidney disease in this country and the way that kidney disease was measured in the SOFA score. And so I don't want to go like totally into the wonky rabbit hole, but like this led to sort of a niche area for me, where I developed some limited expertise and got to publish in some big journals and give some talks and built connections around the equity community on a really specific, but far-reaching topic, that gave me this recognition of the power of having a policy lens to my work and understanding the need for equitable guidance and the way that that would be operationalized on the clinical front lines. And so as we came through 2020, Boston Medical Center went through its own racial reckoning after George Floyd's murder. And many of us were very active in helping BMC, which is a very mission-driven safety net hospital, understand what was needed. The head of graduate medical education at BMC came to me and asked me to do some blue sky thinking to help think about what it would look like to create an interprofessional educational program to train the next health equity leaders for the health system. And so I got the opportunity to sort of think about what's needed to take people like me who like grew up well-meaning and with privilege and got through medical school and into residency, training them to think like a health system transformer. And what does that look like? And so I got to design a health equity fellowship at BMC, and we launched our first cohort in July of 2022 with one nurse and one physician, and built from there. And so the fellowship, I'm going to kind of breeze through because this is like one part of my work, but in the interest of time, I want to get to some of the other pieces of what I do. But there's a novel health equity curriculum that's built a lot on some of the work that many of the other brilliant minds in racial justice work around the country have done. And there's a practical training piece on like how do you mobilize system transformation at scale. And this fellowship is available to people only at BMC. And so it's folks who know the institution and can sort of catalyze change. And so these are our first fellows who graduated last June and are just phenomenal physicians and nurses who are really transforming the systems they work in. At the same time, almost in 2020, I was approached by some folks who I had worked with in the racial reckoning program at Southern Jamaica Plain, and who I knew through my work with the AMA as a member and an advocate for equity policy from the American Medical Association. I was approached and invited to help contribute to some ongoing work that was happening at the AMA. And so in 2018, 19, and 2020, there was an immense amount of policy passed by many of us who felt like equity was under-recognized as an urgent need and an urgent health crisis. And we passed a bunch of policy at the AMA to try to catalyze change. I want to give credit here to Rohan Kazanchi, who's a Med Peds resident at BMC, for this slide and highlighting a number of the policies that we passed. But I was also invited then to join the AMA as staff and to join the Center for Health Equity as the Director for Social Justice Education and Implementation, and think about how we can use education as a lever to drive systems change at scale. And so for me, this was a really fabulous opportunity to step out of not just the institutional or health system level, but also back to the national level, and to think about what national interventions could help to drive change and catalyze change in different places in the country. And so under the leadership of Dr. Aletha Maybank, our phenomenal Chief Health Equity Officer, I joined the AMA in August of 2021. And 2 months later, went out on bed rest with my third child because I'm really bad at being pregnant. And this time I landed on hospital bed rest for my own health reasons. and was on hospital bed rest for a month before Seta was born. This is my little nugget. When she was born, she was not my smallest kid, but she is my fiercest. And she came home from the hospital about 3.5 weeks later. And so this was the fall of 2021, and she is delightful and extremely feisty. And you'll see some pictures of her later on. She's now 3 years old. But during my time at the AMA Center for Health Equity, I've been able to create an immense amount of educational material that's posted on the AMA's EdHub. It's free, it's open access, it's available to anybody. We have developed this in partnership with a number of other organizations. I want to give a particular shout out to COVID Black, who developed a lot of our historical foundations in racism and medicine series with us. Health Begins is a nonprofit, amazing organization that does consulting work and many things. But it's run by my brother-in-law. So Gaurav's brother is also a physician and a public health activist. And many other folks who've contributed to this work. These are just a few examples of some of the modules. But one of the series that I've been able to work on most deeply is creating the National Health Equity Grand Rounds. And so this is a series of conversations that happen both virtually and in 2024 in person to address some of the root causes of health inequities in the country. In May, we gathered in New York City in Harlem at the Schomburg Center. And just last month, and I'll show you pictures of this in a moment, we gathered at Facing Race, the largest racial justice conference in the country that's hosted by the organization Race Forward, to host these conversations of brilliant thought leaders sharing their understanding of what's needed to advance equity in health. This is done in concert with 16 collaborating organizations. We've had many speakers, an immense amount of attendance at these events and viewership over the course of the life of this series. And this is some of the privilege that I have to work at the national level, right, to organize something that gets this type of reach. The other program that I want to highlight from the AMA side of things is something called the Rise to Health Coalition. And this is a national coalition for equity in healthcare that was founded in 2022, launched really in 2023 with the Institute for Healthcare Improvement, the AMA, and Race Forward leading the way, along with Health Begins, the Groundwater Institute, two other racial justice organizations. Groundwater Institute is like the groundwater analogy. There's that parallel there. It's the same metaphor. And this is an effort to align and catalyze transformation of the healthcare ecosystem toward equity, and works with a number of different audiences, including professional societies, healthcare organizations, pharma, biotech, and research organizations, individual practitioners, as well as, who did I leave out? As well as payers, which is also a really unique audience to think about how we can leverage their influence on the healthcare system to drive equity. And we've reached many thousands of people. We have an ongoing learning network series for professional societies, as well as a lot of work to remove race from clinical algorithms from being inappropriately used in clinical algorithms. One of the places that the coalition got to show up recently was at Facing Race, as I mentioned, in St. Louis last month. This is a view from the main stage. Where we had a keynote by Rinku Sen, who is a phenomenal thought leader on narrative strategy, followed by a panel conversation facilitated by Dr. Maybank with Michelle Browder, who is an incredible artist. Look up Michelle Browder's work. She runs the More Up campus down in Montgomery, Alabama, and does some incredible work around the intersection of history, maternal health and justice, and a radical reimagination of what the healthcare system could look like. Next to Michelle is Garth Graham, who is the global lead for Google Health and YouTube, who's a physician and a cardiologist, thinking about how we leverage platforms like that for narrative change, shifting how we think about what creates equity. Mayret Mandefro, Dr. Mayret Mandefro is a physician and an Emmy-nominated producer and writer who brings that lens of how do we use different forms of media and the arts to drive change. And Baylove, who is a just incredible organizer, thought leader, and activist who is one of the principals of the Groundwater Institute, joined this conversation. And we also led two really incredible arts-based activations there and created space for Michelle Browder's work around maternal health justice, and for Lalu, who is a Nigerian-born, actually a lawyer by training, artist who joined us as well to create live art around this theme of health justice as our co-creation. And that art is going to be on display, diversifying the AMA's art collection for years to come. And so it was really beautiful to see this intersection of art and health justice and in this really liberatory space at the Facing Race conference. We have a lot of ongoing work around the Rise to Health Coalition, particularly with professional societies around removing race from clinical algorithms in ways that are inappropriate. And there's, yeah, just a lot going on in this space. But I'll close it out in just a moment and leave you with a few strategies, and we can then jump into questions. Professionally, my roles now include practicing emergency medicine. I love my clinical work and the proximity that it gives me to people whose lives are really complicated, and it keeps my sense of what's wrong in the health system really sharp. I am a co-director for that Health Equity Fellowship that I mentioned at Boston Medical Center, and have an amazing community of practice with deeply invested healthcare professionals that include pharmacists, social workers, nurses, physicians, and healthcare administrators who want to learn about advancing equity in the health system. And then I have this role now. I'm the interim vice president for equitable health systems at the AMA. I get to think about how we drive change at the national level. This all semi fits in with my family life. I have 3 kiddos now and an amazing au pair. My mother-in-law, who you see here, lives with us. We took Sebastian to the Paralympics in Paris this fall. He wants to be a Paralympic swimmer when he grows up. And that was a really particularly special trip. And you can see my feisty 3-year-old Seta, who is named for my grandmother, who I introduced you to before, and our dog Mamba, who is just adding to the beautiful chaos that is the Manchanda household. I can absolutely close there and move to questions, or I can share a few thoughts on some strategies or resources. Hiba, what do you think?
Yeah, please go ahead. This is all for our students to learn from you as much as you can, so you can have around more 5 to 10, I would say 5 to 7 more minutes if you can share
Perfect.
as you can.
Okay, no problem. This part is pretty straightforward, and this is a like piece of my mind, grains of advice, take it or leave it. One of the things that I have that I found really helpful in creating more inclusive spaces and letting people be more human at work and in academic settings comes from some of my experience in working with Abby Ortiz and Denny Butler McKay at the Southern Jamaica Plain Health Center. And so I want to give them kudos for a lot of these tools. But this type, the 2 things I'll introduce to you in a second really work well in any setting. Like this doesn't, it's sort of healthcare agnostic, it's team agnostic, it's topic agnostic. It just lets people be a little bit more aware of who they are and how they're doing in different spaces in ways that let us stay more connected to ourselves, even as we progress through spaces that invite more sort of cognitive or mind-based presence. And so on our team at the AMA, we use these 2 tools, this window of affective tolerance, which I'll explain, as well as identity explicit introductions in as many of our meetings as we can, because it helps people sort of understand their colleagues and the people who are in this space with them a little bit more deeply than just saying, hi, I'm Emily, I'm an attending at Boston Medical Center. That's a really limited introduction, and it doesn't give people a sense of like the things that I think are important about me that I'm bringing to that space. And so the window of affective tolerance is probably the most foreign of these types of things that we invite people to do, because it invites people to actually like pause and think about how their body is feeling in any given moment. It's a somatic number that we're asking people to offer. And the scale runs from -10 to +10. -10 is like you're catatonic, you should probably be hospitalized. +10 is you're manic, you should probably be hospitalized. Most people function somewhere in the -5 to 5 range. And you can't be a 0 because you always have some life force. But that's sort of how the scale goes. And we invite folks to share sort of where are they feeling. Right now, I'm like a 4 or 5. I'm actually not super comfortable with public speaking. It makes me a little bit nervous. And so I feel that in my body. It's just like a little bit of like hyperactivation. On my team at the AMA, it's helpful when one of my teammates, checks in. They're like, I'm actually a -4. I slept terribly last night. Or my cat's sick or whatever is going on in their life. It invites them to share a little bit about where their body is in that moment. And it lets me know as a manager that I shouldn't be asking them to do 3 new things today, right? Like in this moment, that's just not going to land well with them. If it's like, oh, I'm checking in at 3, I'm doing great, like everything's going well. I'm like, hey, let's have a creative brainstorm about this thing. This is a good moment for that. It gives us a chance to sort of gauge how people are doing in a way that is really inviting. The identity explicit introductions are also a way for people to get to know each other. And I really enjoy doing this in spaces where people are not actually equity people. And I always model this first and then tell people, like, please share as much or as little as you want. This can be long, like this presentation, or it can be really short. Usually what I go with is, hi, I'm Emily Cleveland Manchanda. I use the she series and I racialize as white. I'm ethnically Armenian, Irish, and a descendant of some of the first Anglo colonist settlers of what's now North America. I'm an emergency physician by training, and I'm a mom to 3 kiddos, one of whom has significant disabilities and is neurodivergent. And so disability justice in medicine is a big part of what I do. Most of my professional time is spent either in clinical care or working at the AMA, where I'm the director for social justice education and implementation. And that's like 35 seconds-ish. I don't know, I talk fast. But it's an invitation to people to share a little bit more about themselves in professional spaces, and that allows us to build relationships. And so I'd encourage you to think about ways that you might incorporate either of these into your spaces, recognizing that, like, as a student, as a trainee, there's a power hierarchy, and introducing things like this may not be feasible for you. But you can do this within your own circles, within your own student groups, within your friends circles, even, of like, how are you doing today? Checking in on people. Just lets us be a little bit more human and a little bit more connected. Okay, so that's the somatic piece. I do want to just share some of the things that I found helpful in terms of my own learning, my own journey. I am a big reader. I've actually shifted, though, a lot to listening, and I would encourage people to intentionally broaden their platforms. I need to put a blue sky thing on here, and it will go. I'm shifting because, like, blue sky, blue, what am I calling it? Med Sky is way cooler now than Med Twitter. It's like the old Med Twitter before it got gross. But broaden your input. I would encourage you to look at who you're following and intentionally diversify that pool of people. For me, that means intentionally seeking out some conservative people to follow because that gives me a sense of what people are saying in spaces that are not my bubble. But in 2016, 17, 18, it meant intentionally following people of color and other thought leaders in the racial justice movement so that I got a sense of what I was missing. What had I missed? What are these people saying? What's their take on everything that's going on in the world? I've also shifted to listening to a lot of my books because when I find that easier to incorporate into my life, and it helps me move through some of these things. I'll offer you some of the things I found useful, though. Ijeoma Oluo, So You Want to Talk About Race, is a really foundational introduction to race in America. It's wonderful. Ibram Kendi's How to Be an Anti-Racist is also a good one. I think many people have seen that and talked about it in recent years. I think that Harriet Washington's Medical Apartheid should be required reading for every medical student in the country. I'm not in charge of that just yet, but I would make it so if I could. Disability Visibility is an incredibly powerful collection of first-person stories that's curated and edited by Alice Wong, who's an amazing disability justice activist and advocate. And I highly recommend it if you don't know anything or don't know as much as you would want to about how ableism operates in the US. Inflamed is one of the most compelling books I've read in the past decade. Rupa Maria is a physician and an activist at UCSF who has faced an incredibly challenging time since the sort of outbreak of most recent violence in Gaza and her defense of Palestinian rights. And she and I have been in closer proximity as a result of some of that pro-Palestinian work. And she has faced a really uphill battle because of her activism in that space. But this book has nothing to do with, well, no, it doesn't. It actually has a lot to do with that, but it doesn't explicitly talk about what has been happening to Palestinians. It predates that. That's not true either. I'm sorry, let me rephrase. The publication of this book focused more on the connection between colonization writ large and the history of colonization across the world and its impacts on health, from macroeconomics to cellular level inflammation and who gets sicker when they get COVID. It's a really compelling story through a beautiful analogy of rivers and streams and trees and other pieces of nature. But I'd highly recommend that. Racism Without Racists is a fabulous exploration of how racism operates in 21st century America, sort of like the new racism is colorblind, by Eduardo Bonilla Silva. He's a sociologist, and it's a little bit like deep in the weeds of like sometimes in the book he's arguing with other sociologists through his writing, but mostly it's really digestible. And then Heather McGhee's The Sum of Us, I think, is one of, again, the most compelling books that I've read in recent years. It is a really beautiful explanation of how equity and opportunity is not a zero-sum game, that when we address inequities, actually we all win. And Caste was another foundational book by Isabel Wilkerson that really helped me understand how racism operates and is in line with many other types of systemic and structural oppression in other places around the world. So key takeaways from me, you don't have to have it figured all out. A decade ago, I thought I was going to be a plastic surgeon. 5 years ago, I thought I was going to be a researcher. And here I am splitting my time between the AMA and clinical practice. So you don't have to have it all figured out. But it's also important to realize that you can't fix what you don't see, and we all see different things. You have to stay humble, you have to stay empathetic, and keep listening to the people who are experiencing pain, whether that's because they are poor white rural folks who have been left out of economic development in this country, or people of color who've been oppressed here for centuries. It's also, I think, helpful for me to remind everyone that providing different resources, not equal resources, is actually necessary to create equitable outcomes because we're not all starting from the same place. And that if we start from a lens of anticipating the ways that racism, ableism, and other systems of oppression will operate, we can test our solutions in ways that foster equity without recreating the same broken system. And so I will leave you with this quote from Lila Watson, who's an Aboriginal activist and educator, who says, "If you've come here to help me, you are wasting your time. But if you've come because your liberation is bound up with mine, then let us work together." And I will leave you with that. And I am happy to answer any questions, personal or professional. And thank you for the opportunity to be with you tonight.
Thank you so much for this awesome presentation. It was very thoughtful, and I truly have learned so much, and I connected to a lot of the pieces that you have said. So thank you so much for that. Now we're gonna go ahead and open it for questions. So feel free for you guys to go ahead and mute yourself, ask any questions that you have from all the awesome pieces of from the presentations that our speaker had today, or just anything in general. You can unmute yourself, or you can type them in the chat and we'll read them for you. So feel free. Do whatever you want to do to reach out your questions.
I
Oh,
do
well,
see
I
one
typed
of
it in the
Oh,
chat, but
yeah,
I
go ahead.
can just say it. Well, thank you so much for all the information that you gave today. But I was just wondering, do you think that your time in Liberia influenced your decision process when you were deciding what specialty to go into? Just because I also am a very big fan of Paul Farmer, and I'm kind of thinking about possibly like working abroad the way that you did for a while. So I'm just wondering kind of if that kind of influenced how you approached medicine or thought about it when you came back and what you wanted to go into.
Yeah, absolutely. Thank you for the question. Yeah, Paul's writing was deeply influential for me, and some of my mentors now and friends worked really closely with him for many years at PIH. And so his work has continued to influence my own sense of how we address structural violence in the healthcare system and beyond, for that matter. My time in Liberia for me is a little bit complicated. Like, I didn't have a strong racial justice lens at the time. And Paul's writing talks a lot about structural violence, but not a lot about racism, in ways that, like, when you talk to him in subsequent years, like, he clearly has a very strong lens on equity and racism, but it wasn't as explicit in some of his earlier writing. And I didn't have a deep sense of racial privilege. Like, I had a different sense of privilege working in Liberia, but I think that question's a little bit complicated for me in that sense. I It was, however, my time there, very influential on how I think about, like, how physicians, like, help others, and, like, avoiding that, like, savior complex as much as possible, and rather being in partnership with people who are there. Like, we very much took the frame, in the Clinton Foundation at the time in Liberia of, like, "What do you need from us? How can we be helpful to you? What are your priorities?" Not, "Here's what we can offer you," or "Here's the right way to do things." It was, this is what you said you need. Okay, here's what we think would make sense. Which one do you want to do? Which way do you want to go with this? And having truly, like, government-led initiatives that we were supporting. That approach has very much continued throughout my professional career. And it's frankly how I talk to patients. I'm like, what do you need in order to like take your medicine? Like, clearly it's not working for you. Like, whatever we're doing is not working. So how can I help with that? Rather than like, come back when you want to take your medicines and then I'll help you, which is a historically like very physician way of answering patients who are non-compliant. So yeah, deeply influential for me. I also want to just be really clear, like, you don't have to go to Liberia to do that kind of service work. There are like phenomenal racial justice organizations and community-based organizations that are operating in St. Louis, like City Life Vida Urbana in Boston does housing justice work. Like there are incredible ways to do work that gets you proximate to harm and deepens your understanding of how you can help without leaving the country. And that was not something that I knew at the time.
Thank you. We do have another questions here in the chat, and they're saying, can you expand on the emergency medicine aspect of your career, especially in your everyday life? What's the hardest part of it, especially when you are pursuing public health, etc.?
What's the hardest part of the emergency medicine work? Is that the
Yeah,
question?
that's
Yeah.
what they're retaining
Yeah,
to.
just wanted to make sure I heard it correctly. So EM is a really interesting specialty. There are some other specialties where this is probably true, but emergency physicians sort of uniquely, almost uniquely, all have something else that they do professionally in addition to their clinical work. Like, all of us either are, researchers or teach a whole bunch or do public health work or are expert witness for folks, or like, because we do shift work, because I have, I show up at 7 and I leave at 4, and I know when I'm going to be working the month ahead of time or 2 months ahead of time. We all sort of have other things that wrap up into our professional identities. And I think that's a little bit harder to do when you have a technical specialty, like if you're a surgeon or an interventional cardiologist or someone who like has a technical specialty. I think that's sometimes harder to do. And I'll say that like my clinical work deeply informs my public health work. Like, I see the effects of our immigration policy because I'm taking care of Haitian migrants who have nowhere to live and they're living in the lobby of my hospital. Like, I see the impacts of the opioid crisis and the ways that that has shaped people's lives, and the ways that the way we've structured medication-assisted therapy, like methadone and access to Suboxone, in ways that disproportionately harm people of color and make it harder for people without economic resources to access treatment. Like that, the clinical work, like it is true frontline medicine. We take care of the people who are left out of the rest of the functioning the rest of the functioning medical system. And so I'm really proximate to the ways that our medical system is failing and the ways that our public health system is failing. I'm also proximate to like some of the ways that it works. But that's really helpful for me in shaping how I think and talk about the solutions that are needed. The hardest part is telling people that there's nothing that we can do or that they lost a loved one, especially when that's a child and I have to tell a parent that. That's the worst part of my job every time.
Thank you for elaborating on that. We do have another question here saying that they're also interested in emergency medicine and they want you to talk more about your experience in emergency and what kind of like the medical cases that you come across.
Yeah, absolutely. So I mean, as an ear doc, I see literally everything, like everything, and sometimes right next to each other, from penetrating trauma, from gun violence or stabbings, to like I dropped a brick on my toe and it really hurts, and literally like one after the other. You never know what you're gonna get. I mean, you can pretty much guarantee that a Monday evening shift is gonna be busier than a Sunday morning shift, but you never really know how things are gonna unfold. I will say that I very intentionally chose and had the opportunity to work at a safety net system that is very mission driven. Boston Medical Center, since its inception, has aimed to serve the most marginalized patients in our communities, and has set itself up to do so in ways that take care of people, not just in the clinical context, but beyond. And so I work in a place that has a really strong violence intervention and advocacy program that provides wraparound services, including counseling and social work and community care for victims of penetrating violence during their hospitals, like literally in the trauma bay sometimes with me, and in their whole course and afterwards. Do I have time for a quick patient story? I think we go until the half hour mark. We have time, right? I think I do. I'll tell you a quick patient story. So one of the first patients that I took care of as an attending at BMC. And this is in like, I don't know, April or May 2020. So like during the COVID pandemic. It was a woman who came in, and her chief complaint, like what it said on the board, was med refill. And it was a shift when the residents were at their conference. And so I was working, I was directly seeing her myself without the residents seeing her first. And so I walked into the room and I introduced myself and said, oh, I heard, saw that you need medications refilled. What do you need? And she told me what they were. And I said, okay, can you just tell me a little bit more about what happened and why you need them? And as it turned out, she explained to me that she had recently been trafficked to East Africa and had just gotten back to the United States a few weeks ago and had been in New York City and had been staying in a shelter and had gotten her meds and had had some care, but her meds were stolen in the shelter. And she heard the Boston Medical Center could probably help her because she was turned away from an ED where it said, like, I can't prescribe you any more of this controlled substance because you just had it. And like, I don't know whether you just abused it. And they turned her away. Or didn't refill her medication. And so she got on a bus, or somebody bought her a bus ticket, and she made it up to Boston Medical Center. And I was like, okay, like it's a lot more than a medication refill. You don't just need a prescription, like you need a whole bunch of other things. And so we had this conversation to try to outline what she needed. And I was like, I'm pretty new here. Let me see what we can do. Like I can certainly write you your medications, but let me see what else we can do. And because of how Boston Medical Center is structured as a health system, by the end of her visit, she had a primary care appointment later that month. She had a place to stay at a women's shelter. She had an Uber voucher to get her there. She had her medications, not just a prescription, but filled at the pharmacy and brought to her bedside. And then as we left, I walked her downstairs to the food pantry that was in our basement to get food for the next 2 weeks that she could take with her to the place where she was going to be staying. And at the end of that encounter, she looked at me and she was like, I just can't believe this happened. And I looked at her, I was like, honestly, neither can I. Like, it was the most rewarding clinical experience that had almost nothing to do with like the medical training that I got in medical school or residency, and everything to do with how we structure our healthcare system to meet people's needs. And that's a like that has stayed with me in ways that continue to like create empathy for me, for the people who come in just because they're cold or because they're hungry or like for things that are not medical, right? I get to be really proximate to the ways that society harms people. I also get to take care of people who have gunshots and who are like critically ill with diabetic ketoacidosis, who we get to like, I love critical care medicine, to be really clear. I actually like love taking care of really sick patients. And that gives me great joy. That's actually my preferred shift, is our trauma/resuscitation shift, where I take care of like the septic patients and like the injured patients. Like that's, I don't love our fast track area where I'm mostly doing med refills, but I've intentionally chosen to do emergency medicine in a context where I'm not forced to turn people away when they want a blanket.
Perfect. Thank you for that. And thank you for everybody's questions. We do have multiple questions about like what are your advices for people that are going into medical school? If someone chooses a major that's not health related, do you think that's going to affect them applying to medical schools or DO schools or whatever like health sciences they want to apply to? And they also have questions about how do you think they can gain their clinical hours and all of that like exposure as they approach their professional programs.
Yeah, really, really great questions. So with the caveat that I am not on an admissions committee, so I can't say this for certain, there has been a shift in medical education toward valuing people's life experiences. And that doesn't just have to be like pipetting in a biology lab as a summer intern. And a recognition in medicine that good humans make good doctors, and that you don't just need to know the Krebs cycle or biochemistry in order to be a good physician. You actually have to know how to talk to people. And so, my French major, I actually wrote my thesis about novels written by North African women living in France, and spent a lot of time thinking about like the othering that happened in France in French. And I think studying another language or speaking another language just inherently gives you a different perspective on the world. Like there are literally different words for different emotions that don't exist in another language, right? And I see some heads nodding for like, yeah, there's like just not a word for like how that feels. And that creates empathy. And there's science behind that. that like kids who grow up exposed to another language or speaking another language are more empathetic than kids who grow up fully monolingual. And so I would encourage everyone to study what you find interesting, because you'll be good at what you find interesting, and to not be constrained by like, I have to do a biomed major. Like if you love psychology, like study psychology. Great. If you love biology, study biology by all means. But you're never again going to get to like take art history classes and be compensated for that with a degree, if you want to be a doctor. And I think that like analysis and being in spaces where people saw different things when looking at the same picture was also really influential to me when thinking about how people approach problems, whether you're talking about public health problems or clinical problems. So I would encourage you to take that advice that I took from my advisor, and like use med school to study medicine and use the other time to study what gives you joy. Else, the obvious caveat probably is like you have to also like do well in school to get into medicine. Like there's still like parameters for demonstrating that you will do well in medical school, and some of that is standardized testing, unfortunately, still, and some of that is like your grades, and some of that is your letters. And so I think valuing experiences that bring you proximate to people who will give you advice on how to proceed is really helpful. And so and that can look different in different specialties. So I think I got most of those. There was something else I feel like I didn't answer. Please jump in if I didn't answer your question and it was tied up in there.
It was, how do you advise them on like gaining their clinical hours before they approach their professional schools?
So that's a good question. I did not have a lot of like shadowing experience. Well, actually, that's not quite true. In high school, my high school, like you had to do an internship program for like 3 weeks at the end of your senior year. And this is honestly like it's not going to be relevant because it was in 2003. But it's also not relevant because it's before there were a lot of really stringent privacy laws in place. And so I talked my way into, I like cold emailed the chair of trauma and critical care surgery at a major university hospital that I probably shouldn't name because this is being recorded. I was like, hey, can I come shadow you? I want to be a surgeon, or I want to be a trauma surgeon, or whatever I wanted to be at the time. And they're like, sure, come, we'll split your time between like shadowing in the emergency department and shadowing in the trauma surgery service. And I like was in the OR, I was in the ED, like all the, like, it was just like, yeah, show up, you'll shadow these people. It was very, very, very informal, and not possible at academic medical centers now, which is a good thing for patient privacy. But I think, programs like pre-health shadowing, I think give you some exposure to like, I never knew, to be clear, that like emergency medicine doctors did other things with their time. Most of us do something else. One of my co-faculty is a state senator. One of my co-faculty runs an immigrant and refugee health clinic. Like one of my co-faculty, like there's like, we all do something else in addition to our clinical emergency medicine work. One of our co-faculty is the vice president for mission for the health system. Like there's, a lot of, or like the head of all graduate medical education for BMC, and still practice clinical medicine in the emergency department. So I think programs like this definitely give an increased amount of proximity. And I think like just asking people their stories also gives you a sense of how they ended up doing what they're doing. And so like the next time you see your doctor, like ask if you can have a separate conversation about what they do and if they like it. I think that's also, one route to sort of broaden your sense of what's possible.
Thank you for that. We do have a couple of questions about what are your advices for students that want to go into emergency medicines, and you as a professional already in emergency medicine, how do you find the balance between your medical career and family and research and all of these practices?
Yeah. Well, I don't have it figured out. It's not a balance. It's like I'm constantly juggling and trying to figure out which balls that are in the air are glass and which ones are bouncy balls and which ones are plastic and probably won't break. That's like the best analogy that I've had for myself for this year. My marriage is definitely a glass ball. Like that is one that like is like central to like me as a human, and like my role as a mom is also in that space. Although sometimes like parts of being a mom I can offload to other people without compromising like I don't need to be the one to pack my kids' lunch. I actually hate packing lunches. I find it like annoying and kind of stressful, but I don't mind picking out the kids' clothes. And so like I'll do that the night before, but I have, our nanny do the lunches. So some of it is kind of that type of balance. I think you also just have to know yourself a little bit. Like some people, very much not me, some people really like to focus on one question and one problem at a time. And like Anthony Fauci is like this. If you listen to him talk about his career, like how he was able to like do what he did in many of his roles was like by hyper focusing and tuning out the noise and like focusing on this one problem and building a team to address this one problem, like creating a COVID vaccine. I am not that person. Like some people really like to see something start to finish. I get joy from pulling in inputs from different places. And like this morning I was mentoring a medical student, and then I went from that into a conversation about my fellowship, and then I went from that to a meeting with my team at the AMA about like how's everybody doing. We listened to some professional development presentations, and I had a strategic conversation with the Center of Health Equity Leadership about what are we doing now and next year and how are we prioritizing and holding ourselves accountable. And then I went downstairs and helped my mother-in-law prep dinner and like started being Santa. Don't tell my kids. I was arranging stockings, and then came back to this conversation. And this is a joyful day for me. But that would give people who like to focus on one thing at a time so much stress. And so I think knowing yourself is really important. Like if you love doing something and doing it really well, like you could be a cardiac surgeon. Like they do a very specific thing. And so it's different from patient to patient, of course, but like it's kind of the same thing over and over, and they're really good at it. And that is not my happy place. Like I'm so glad that pediatric neurologists exist, and you couldn't pay me enough to be one. And just knowing yourself and what gives you joy, working with teams, working with what types of patients. Do you like seeing people over and over again and helping them like gradually build toward a better version of themselves? Or is that not super important to you and you want to be there when people are having a terrible day and be that person who makes that terrible day less terrible? Like these are the types of things that I think are really helpful when you're thinking about what to pursue. And there's not a right answer. And like this whole, like there's some prestigious specialties or not prestigious specialties is like absolute nonsense. Like there are a whole bunch of very prestigious physicians who are very unhappy with their life choices despite making lots of money. So like truly encourage you to pursue what gives you joy.
Perfect, thank you. We do have a question here. They're saying that I'm a public health student assisting clinical trials for people in rural Eastern New York City. I have seen how less access to care has affected their health, and I was wondering if you had any advices for advocating to improve the system to serve these people.
Yeah, thank you so much for that question. And I'm seeing it in the chat as well. I'm like trying to scroll through. Man, rural Eastern North Carolina is like a very different place than where I work. And there are some really foundational ways in which our health system is set up to fail many people, some people, not others. And so I guess, okay, this is me very definitely not speaking as AMA staff, just so everyone is clear and I've said it out loud. This is like Emily as Emily, in my personal opinion. I don't think that we can have an equitable healthcare system when we inequitably fund care. I don't think that with differential funding for people based on insurance status that you can reach an equitable healthcare system. When I, as an emergency physician, do the same thing for two patients who have a heart attack and I get paid more for one of them than another, it's actually not true in emergency medicine because I'm salaried. But like when a cardiologist who has a private practice gets paid more for seeing Medicare patients than seeing Medicaid patients, they're not going to see more Medicaid patients. And like you just don't have an equitable system that way. And so I think everything that we can do to get to a unified financing system, it does not have to be a single payer system, but a unified financing system that pays people who provide care the same amount, regardless of who they are caring for, is probably the most foundational way that we can get to more equity in healthcare. And I'll just say that like, this is like seeing healthcare as a public good is also, and not a privilege, is also just like a foundational shift for our society now, that I think is a really crucial one for us to make. There are parallels in education. Like we've just collectively as a society decided that we value rich kids' education more than poor kids' education because we tie school funding in public schools to property value and property taxes. Like that's fundamentally bonkers to me. And it's something that we just like collectively decided is okay. And we sort of do the same thing with healthcare, where like you get more care, better care if you're wealthy or if you have a certain type of a job that if you're disabled or don't have access to that fancy education that you cannot get. And so addressing some of those really foundational, structurally unjust pieces of our society in the ways and places that we can is, I think, the actual answer. Now, like, what do you do tomorrow? Well, that's a lot of community organizing and like talking to people and like creating voting blocks around equitable and just policy agendas. And I think helping people see that, like, this is maybe the last thing that I'll offer. Most people don't have a structural lens. Like in healthcare, I think we've gotten many people, maybe even most people at this point, to understand that like if you don't have a house, you can't have a refrigerator to keep your insulin in. And that like housing is tied to health, right? It's hard to be healthy. It's almost impossible to be sober if you have a substance use disorder if you don't have a house. And that like housing is really foundational and a part of health. The same is true for like language access. If you don't speak English and the healthcare system's not providing interpretation, like it's really hard to access healthcare. If you don't have healthy food, like food is health, right? And that we've started to get people to this understanding that like social drivers of health are part of our responsibility to address in the healthcare system. What we haven't gotten most people to is an understanding of what structures, what policies and laws shape the distribution of social determinants of health inequitably from one population or one neighborhood to another. Like that structural understanding of like, this is not by accident. This is by law and by choice and by policy made by people who are in those positions of power, whether they were appointed or elected. And those are policy decisions that shape the distribution of social determinants of health. And when you see that, it helps people understand, whether you're a patient or whether you're a clinician, that like, it's not that you're not working hard enough to be healthy. You're not like making bad choices. And that's why you're living in this like mold infested apartment that's setting off your asthma again. And so you're missing work again. So you're going to lose your job again. It's not your fault that that is happening to you. There aren't bootstraps that you can find to like pull yourself up. Like this is you're experiencing structural violence. And that creates the opportunity for a little bit of self-forgiveness. And also creates the opportunity for like, oh, maybe we should be thinking about who we're electing differently. And so that's Emily's soapbox these days.
Thank you. We do have a question here about if you can elaborate about the differences between rural medicine and urban medicine, and which one would you recommend?
Yeah. So a lot of the inequities that we see in urban settings are actually really mirrored in rural settings. There are different stressors on the systems. Like in rural settings, emergency medicine docs spend an immense amount of time working on transferring patients from their facility to tertiary or quaternary centers of care. And the transport pieces and like having patients accepted at different health systems and how that's shaped by their insurance is a really different experience than what I'm at the receiving end of those patients in a safety net system that always says yes. And so like that's not my stressor. My stressor is that I have no beds left in my hospital and I'm taking care of 40 patients on the side of the ED that has 12 rooms and taking care of people in hospital beds because people don't have access to longitudinal care or preventative care in ways that would keep them out of the health crisis that brings them to my emergency department. You get some of that in rural settings as well, and like the overcrowding, but the boarding, like the overcrowding is because you can't transfer people out more so than, well, I don't know. It's also a primary care problem. So we underfund primary care, so there's a lot of similarities. I think the EM docs who work in rural settings and critical access hospitals have a lot fewer clinical resources to rely on, to fall back on. I work in a place with 24/7 orthopedic surgery, trauma surgery, neurosurgery, all of the surgeries, all of the specialties are always on call in my hospital. And that's just a very different clinical practice. For someone who works less clinically, like I work 5 to 6 shifts a month clinically, that gives me some comfort that like there is always a specialist to call. And it's not just me doing a procedure that I'm like, oh, I haven't done that one in like a decade. That for me right now, because of how I'm splitting my time, feels more aligned with my sense of safety and providing excellent care to patients.
Perfect. Thank you. We have a question here saying someone's asking for your opinion about the knowledge between the difference between the Canadian health system and then in the United States. Elaborate on that. Then they also have another questions. They want to ask about what was the hardest year or the most demanding year in the medical school when you had it, and how did you navigate it or come over it?
Yeah. I'll answer the second question first. My hardest year of med school was my my third year, like my clinical rotations year, and then like taking my step exams. And I managed that by running. I was a runner. Like it was my version of meditation before I knew how to meditate. Which I highly recommend to everybody as a stress reliever. And I got there through, well, whatever. It's a longer version of my story that I didn't include. But yeah, I was a runner. And so I got through studying for step exams by training for a marathon. That was my coping skill. Because it got me physically active and turned my brain off for a little while. But I think staying connected to other people around you is critical throughout all phases of training. But realizing that like you're not actually alone, even when you feel alone, and maintaining connections to your friends, especially people who are outside of medicine, and family, if you have folks who are not in medicine, especially, is really important. The differences between the US and the Canadian medical system are profound. Let's see where to begin on that one. I mean, there's universal healthcare in Canada, so like everybody gets healthcare. I don't actually know that much about the Canadian healthcare system, so I don't want to misspeak and like say anything, that's terribly wrong. I think some of the sort of straw man arguments against universal healthcare, or like socialized medicine that people put up, are like, oh, they have rationing. The wait times are crazy. I'm like, yeah, when was the last time you could see your primary care doctor like next week? Like never. Like we ration irrationally. Like it's not an actual functional system. It's based on like how well you can like navigate the healthcare system, or how many doctors you know that can call and put in a call for you. Like to get my brother's best friend who has lymphoma into Dana-Farber to be seen because he wasn't getting care that he needed in a timely manner in another system, I emailed my friend Umar, who's a hematologist at Farber, and like that's how he got in to get seen. And that's not a functional system, right? That's not a system. That's like a friends and family deal that is deeply harmful to people who don't have access to physicians themselves in social ways. So I don't know that I mean, that probably also happens to some extent in Canada, but it's not like the reliable way to get healthcare is by like finding a doctor who you know and asking them to pull a favor for you. And I think I've seen that happen over and over in the US healthcare system in ways that just, yeah, that are really problematic.
Thank you again for everybody's questions. It's been very thoughtful. We do have another one. Would you recommend going to medical school before pursuing the research or the PhD, or would you like to do it or recommend doing it during medical school?
I think if you're going to do a PhD during medical school, because of the funding that brings for your medical school education, makes a ton of sense. Like PhDs generally fund the MD part of your degrees. And I think it was valuable for me to get my MPH after having like some clinical time. Like that brought me a really different perspective on the healthcare system and what public health had to offer. So I don't think that there's a wrong way to do it necessarily.
Thank you.
Yeah.
What are your viewpoints on AI's role with change in helping the doctors in the future and addressing the racial or the inequity over time as we come across?
Yeah. It's a really good question and a ginormous question that I think we're all sort of in the equity space grappling with. I think there's immense promise in AI in making physicians' interactions with patients more human. Like having an AI tool listening to and scribing for me would be phenomenal because I can then do that and not type all the time while talking to patients. And just processing that and reading that, and like some of the ways that AI holds promise for prompting, like, hey, did you consider X, Y, or Z diagnosis? Because this patient has some stuff that kind of sounded like that to me. And for me then to be able to be like, oh, that's a good idea, I should test. They're like, oh no, that's not actually true. I don't think that's why, whatever. I think that holds immense promise. And as with any meta-analysis study, so for folks who've done research, like a meta-analysis looks at a whole bunch of different research studies and synthesizes the results. There's a very sort of clear saying like garbage in, garbage out. If you have crappy studies that go into a meta-analysis, the results are going to be garbage. And so if you feed an AI system or solution racially inequitable data, you're going to get racially inequitable algorithms. And so we have to be really cautious about what data we fill in and how we're using race and what we are using race as a proxy for. Like I didn't go into any of this, but like race has no biologic reality. There's no biological difference, genetic difference between Black people and white people and Asian people and Hispanic people and any other group. And so if we're using race as a proxy for biology, it will harm people. If we're using race to drive reparative interventions because of the experience, using race as a proxy for the experience of racism, that might sometimes get us closer to reparative solutions, maybe. But really, we need better ways of measuring the effect of racism on people's bodies, either as proxies or directly. So I remain optimistic about some aspects of it and very conscious of the harms that it has driven in terms of some of the healthcare economic considerations and insurance considerations.
Yeah, thank you so much. Yeah.
Thank you. I think I've gone through all of the questions. Hopefully I did not miss anybody. But if I missed anybody or if anybody have any questions, you can go ahead and mute yourself before we wrap it up.
I had a question. I kind of put it in the chat, but I don't know
Oh,
if it,
sorry about that. I missed it. Sorry.
it's good. But I'm a public health student as well. And I'm taking a gap year because I just graduated from college. And I'm trying to find like clinical opportunities that would like help me like center around public health, my interest in public health and health equity. And I was just wondering like what would your advice be in like going about that and like how to seek those opportunities out?
That's a really good question. It's so different from like when I was a student, so I don't know that I have like an easy answer for that. I think you can absolutely reach out to faculty at a school of medicine in a hospital near you and ask if they have shadowing programs. Some do. You can also try reaching out to the state medical society where you live. I don't know where you're based.
I'm in Indiana.
Indiana. So you can reach out to the Indiana State Medical Society and ask if they have any pre-health like shadowing programs, or if they have any like physician mentoring programs where they might be able to make some connections. Physicians in private practice have different policies than physicians at like quaternary care academic hospitals. And so like there's sometimes different levels of flexibility or structure to programs. And then if there are public health physicians in the state, public health department, you could also try reaching out to them because they're all, folks who are like psyched about bringing in more public health physicians. We need more of us.
Thank you.
I am gonna have to hop off really soon. I have a unexpected double date with my brother and his fiance and my husband tonight, and I don't want to make them late, and I want to kiss my kids to go to sleep before I take
To wrap
off.
it up.
But if yeah, cold email physicians, Natalie, honestly, it's great advice. So yeah, if I think if anybody has further questions, you're welcome to reach out to me. And I will I'll share my slides with him minus the like photos of my kids because I try not to distribute those publicly. But I'll share those later tonight or tomorrow.
Thank you.
Thank
I'm
you
gonna
all
go
so much.
share out my
But I do wanted to say thank you for being such an inspiration in like working with minorities and working for making this gap of inequality smaller, and for all your work. I think it's been really inspiring to hear you talk about your work and just to get to know you.
Thank you so much, Maria. I appreciate your kind words.
Perfect. Thank you guys so much for being here today, for talking, asking your questions, and it's mostly for our professional for taking the time out of your family, responsibilities, and also be here. We do like to hear all of you guys' feedback and points on how we can improve, be better, and all of that to meet you guys' or abilities and recommendations. So you can always submit recognitions on our website. Quick form, you can submit whatever you have on your mind. How did it go? How do you want us to improve? And all of that you have for us. Again, you can always join us as a volunteer or a team member. If you want to be more into the loop with PHS than just joining our Zoom. Of course, joining here means a lot to us. You guys are the ones that are helping us expand, be better, and have these resources out for you all. So thank you so much for joining us. Again, donations are a very big part of our organizations to keep it going and keep it nonprofit and accessible to everybody for free. So if you can always save the QR code, share with everybody that you know that can help us gain more donations, it will be very appreciated. You will be able to gain your digital shadowing certificate for this session today. The quiz is already on the website. You can always go after this session, take the quiz. It's a very easy 10-question quiz for you from this session, and you'll be able to download your certificate right after you take it when you pass it. And you do have multiple attempts to take it. It's not very hard questions, it's very easy. It's everything based on what we had and heard today from the presentation. If any questions or problems or concerns that's not working, you can always email us at info@prehealthshadowing, and we're very happy to help you with any concerns or conflicts that you're facing with it. This session will be recorded, and so it will be posted on our website and YouTube channel. So if you had to step out or do anything else, or you missed any part, or you want to rehear anything, it will be up for you. You can always revisit it. And we do also have our old live sessions that we had, so you can always take the quizzes for the past ones and watch the lectures for them, and then take any notes or just rewatch whatever that you need to learn from. It's all available on our website and our YouTube channel. To be in the loop with us more at PHS, make sure to join our mailing list and to look at our website to see all of our future events, our new sessions that we have scheduled. We do have a lot of multiple ones coming up our next year and in January, and they're all very interesting in different aspects of medicine, so look out for them. And so yeah, that's all for today. Thank you so much for everybody for joining us, and especially for the ones that have their cameras and the ones that are muted and asked their questions. It was very thoughtful and very honorable of me to be here and hosting your session today. So if you have any questions, you can feel free to stick around, and if not, see you soon later.
Thank you.
Of course, thank you.